cardiac function is essentially the result of the cardiac cycle, right? Cardiac output is the single most important thing the heart does. Without cardiac output, we don't have perfusion. Without perfusion, we don't have homeostasis. Okay, so in the end, what the heart needs to do is it needs to move blood forward. Now, the way that it moves blood forward is by contracting and relaxing in a rhythmic pattern, right? Well, inside of each contraction and relaxation, there's a number of different things that are happening for different reasons. That's why this is laid out the way it is. Okay, so along the x-axis, this is time. Along the y-axis, we got lots of different things we're looking at that all line up over time. Okay, we'll start with the bottom one because it's the easiest to understand. The bottom one is what you hear, phonogram. These are your heart sounds, right? Lub-dub, lub-dub. So there's a first heart sound and a second heart sound. Those are both always normal, okay? You expect to hear those. There can be pathologic abnormal heart sounds. So there's a third and a fourth heart sound as well. Here in this picture, we have a third. Technically, it is pathologic, but that is a question for another day. We're just looking at the fizz today, okay? So lub-dub, lub-dub. Now, sounds. Heart valves make a sound when they close, not a sound when they open. So it's just like a door. You can't make a sound by throwing open a door, right? But you can slam a door pretty good and make a good sound. So what you hear in the heart sounds is you hear valves closing, okay? First, you hear your AV valves close. That's on the left and the right side. Then you hear your aortic and pulmonic valves close, okay? So along the bottom line, that's what you hear. Next one up is the ECG. We're going to spend a whole session talking about EKG, what it is and how it works. Short version, electrocardiogram displays the electrical activity of the heart. Just like skeletal muscle, heart muscle needs to depolarize before it can contract. So what we see in the ECG is the depolarization and repolarization of different parts of the heart, okay? So the first bump is called the P wave, QRS is the tall squiggly bit, and then the T wave is the sort of rounder curve that follows the QRS. Like I said, we have a whole session on this, so don't worry about getting all that right now. Okay, so we can see that, we'll come back to that. So EKG, and I'll make connections in a minute. Blue line, that's volume, ventricular volume. I told you yesterday that the heart's main function is for the chambers to get smaller and therefore push blood forward. So if the chambers get smaller, we're going to see changes in volume, right? When the heart contracts, the ventricular volume is going to shrink because we're squeezing the blood and making it exit. So that's the blue line. Red line is pressure, all right? So the red line and the dotted lines are pressure. In the dark red line is pressure in the ventricle, okay? The dotted black line at the bottom is pressure in the atria. And then the dotted black line at the top is pressure in the aorta. Okay. Now, so if we look at a cardiac cycle, okay, first thing that happens is our P wave. P wave is the atria depolarizing. In other words, the atria getting ready to contract. Like skeletal muscle, heart muscle has to depolarize, then it contracts, then it repolarizes so that it can do it again, right? So the P wave, depolarization of the atria, the electrical depolarization. Not long after that, we see an increase in both ventricular volume and ventricular and atrial pressure. Why? Because the P wave caused the atria to contract. when the atria contracts, it pushes a small amount of blood into the ventricle. So we get a bump. This is the amount of blood. The difference between here and here is the amount of blood the atria pushed into the ventricle, right? So we get a little bit of active filling, we call that. Atria contracts, pushes blood in. Now, at this point in time when the atria is contracting, the valve is open. The AV valve is wide open. So a change in atrial pressure, because it's now squeezing, is also detected in the ventricle because the valve's open. So the pressure of atrial contraction is seen in the ventricle as this little bump. Now, if you look at the dotted line, you can see that the dotted line also has a bump because the atrial pressure is going to go up too when the atria contract. All right? So, P wave, atrial depolarization, atrial contraction. Now we just finished filling the ventricle. Okay, so next up in the EKG is the QRS complex. QRS is the trigger for ventricular contraction. Okay, and it happens a lot faster than the atria. So here is our trigger, and then lo and behold, pressure starts to go up in the ventricles, red line. Why? Because now the ventricle's contracting. All right? Now, at first, when the ventricle first starts to contract, one of the first things that happen is blood tries to flow backwards, right? And closes the AV valves. So we can see that as soon as the ventricle starts to contract right here, the AV valve closes. Oh, I was trying to use the mouse. The AV valve closes here. Now, at this point, we have an interesting situation for the heart. All four valves are closed. The AV valves are closed, and the pulmonic and aortic valves are also closed, which means there's no way for anything to go in or out. So, as the ventricle contracts, we see pressure increasing here, but we do not see volume changing. See that? The volume is the same, the pressure is increasing. We give this a name. This is called isovolumetric contraction. And what is happening in the heart is pressurizing. Atrial pressure is very low. Aortic pressure is very high. To go from low pressure to high pressure, we got to make some squeeze. That's what's happening in this steep line right here, isovolumetric contraction. Now, at some point, about here, the pressure in the ventricle becomes greater than the pressure in the aorta. Well, physics says pressure gradient, if it's high pressure on one side, low pressure on the other, if it can flow, it will, right? So it pushes the aortic valve open at this point, and then we see the heart continue to contract, and then about midpoint, it starts to relax, okay? Now, it is between, so aortic valve opens. At that point, ejection begins. Remember I said the heart's only job is to move blood forward. The only time it moves blood forward is during the ejection phase. So between when the aortic valve opens and when the aortic valve closes, that's the work of the heart. That's everything else is to make that part happen. So that's ejection right here between aortic valve opening and aortic valve closing. Now, what causes the heart to relax? Rhythmicity, right? There is no signal for relaxation. There's a signal for contraction. Relaxation happens all by itself. Okay, so we get a contraction that gets to its maximum about here. Then relaxation starts to happen. Pressure starts to fall. At this point, pressure in the ventricle becomes less than pressure in the aorta. Now you've got blood trying to flow backwards from high pressure to low pressure. The valves evolved so that backwards flow causes them to close, right? So as pressure in the aorta exceeds the ventricle, aortic valves close. That's our second heart sound, right? That's the dub. Okay, now we're in a similar position as we were over here. All four valves are closed. right? So it means that nothing can enter or leave the heart, but the heart is still relaxing. So volume does not change, but pressure is decreasing. That's isovolumetric relaxation, right? Where the heart is all closed up, but it is relaxing and its pressure is dropping. Now, if we look at this volume curve, we see those same events. Okay, here's atrial contraction resulting in ventricular filling. Then the AV valve closes, so we have no change. Once the aortic valve opens, our volume decreases rapidly. That's ejection. The heart is emptying. Okay. Then when the aortic valve closes, that emptying stops because the door is closed. No change in volume, right? Because the heart is relaxing. When the pressure in the ventricle becomes less than the pressure in the atrium, that's at this point, the AV valve opens. Okay, so now the door to the atrium is open. And now the heart can start to fill again. Now, in this region right here, the heart is in diastole. It's relaxing. The AV valve is open. The aortic valve is closed. So blood is flowing from the body through the atria and into the ventricle in this section. We call this section passive filling, all right, because blood is sort of trickling under its own venous pressure through the atrium and into the ventricle. So the ventricle fills. Then the atria contract again. Here's our P wave, atrial depolarization. Now we see a change in the volume curve because the atria contract, send a little bit more blood in, and then we start the whole process again. Yes?
What's the small sound then in the
Here?
phonocardiogram? Yeah.
That's third heart sound. That's pathologic. So what makes it is filling. It's the sound of passive filling. And you hear it, we say it's pathologic, but you can also hear it in people who have very fit hearts because their hearts beat slow enough that as the heart is filling, you can hear the blood filling the ventricle, and it makes the third heart sound, right? So third heart sound goes along with passive ventricular filling. Then we get active ventricular filling, and then we go through the thing again. Okay, so off to the side of my pictures, I try to point out the key points for each diagram. Okay, so there's going to be several slides with this same kind of a picture. First, systole versus diastole, right? Systole, unless it says specifically atrial, okay, systole means ventricular systole. That is when the ventricle is contracting. So systole begins when the AV valve closes, and it ends when the AV valve opens, right? We'll talk about why valves open and close in a minute. Okay, rate matters here. As the heart rate increases, the first thing that decreases is the time between beats, right? Because the heart needs a certain amount of time to contract and relax. As heart rate continues to increase, then what we get is an increase in contractility where the heart actually contracts faster. Now, the downside is the faster the heart beats, the less of this we have, the less diastole time we have, okay? Diastole is when the heart fills up. So when the heart is beating really fast, there's very little time for it to fill before it contracts. What that means is at high heart rates, our cardiac output actually starts to fall. It's one of the reasons why we worry about somebody who has a heart rate of 150, let's say. Why is too high bad? Because there's no filling time. There's no time for the heart to fill up before it contracts again, and it tends to reduce cardiac output. More on that later. All right, the atria. Notice the little nudge points. It isn't a big like, ooh, squish, we're going to dramatically increase the volume. It's a little bump, right? So here's the atrial bump, here's the atrial bump. So this is volume, how much extra blood is being pushed in. this is pressure. We do get a small amount of pressure from the atria, but it's never enough to cause any valves to open or close. Okay. And then finally, the atria don't contribute to forward flow. In other words, ejection is 100% ventricular. The atria do not participate. All the atria do is help the ventricle to get as full as it can get before it empties, right? Now, there's good reason for that. The heart has a property that the more full it is, the more completely it empties. So the atria help with that process.